Hello everyone, hope you all are okay in this pandemic. Stay safe, stay at home. Okay, I am going to present vocal cord paralysis under the supervision of Mr. Indranil Chatterjee. Vocal cord paralysis is also known as recurrent laryngeal nerve paralysis or vocal fold paralysis. It is an injury one of both recurrent laryngeal nerves which control all the muscles of the larynx except for the cricothyroid muscle. The RLN, that means recurrent laryngeal nerve, is important for speaking, breathing and swallowing. Vocal cord paralysis or can occur at any age or sex. Effect of vocal cord paralysis may vary patient's use of his own voice. Typically, patients with vocal fold paralysis or paralysis are able to identify their onset of their symptoms. Anatomy of the larynx, laryngeal nerves, you can see recurrent laryngeal nerve and superior laryngeal nerve, cartilages of larynx, laryngeal, these are the laryngeal muscles, recurrent laryngeal nerve. Recurrent laryngeal nerve RLN is also a branch of the vagus nerve. The left RLN is found inferior to the aortic arch and posterior to the ligamentum arteriosum. The right vagus nerve continues posteriorly to the roof of the right lung, giving of the right RLN which loops around the right subclavian artery. The recurrent laryngeal nerve continues superiorly bilaterally and pass posterior to the lobe of the thyroid gland as they travel along the lateral surfaces of the trachea and esophagus in the tracheoesophageal groove. The nerve pass posterior to the cricothyroid joint as they enter the larynx. At this point, the RLN becomes inferior laryngeal branch of the recurrent laryngeal nerve, excluding the cricothyroid muscle. The inferior laryngeal branch of the recurrent laryngeal nerve innervates all intrinsic muscle of larynx. Superior laryngeal nerve. The superior laryngeal nerve is a branch of a vagus nerve. It arises from the middle of the inferior ganglion of vagus nerve and in course receives a branch from the superior cervical ganglion of the sympathetic nervous system. The cricothyroid muscles are innervated by the superior laryngeal nerve. All other intrinsic laryngeal muscles are innervated by the recurrent laryngeal nerve. Superior laryngeal nerve consists of two branches, the internal laryngeal nerve, which supplies sensory fibers to the laryngeal mucosa, and external laryngeal nerve which innervates to the cricothyroid muscle. Symptoms of recurrent laryngeal nerve damage: rough voice quality, breathy voice quality, vocal fold bowing, decreased vocal fold mobility, glottal insufficiency, hyperfunction, vocal fatigue, reduced vocal stamina, changes in the voice pitch, difficulty in varying pitch or quick rate, difficulty in projecting voice or speaking loudly or in noisy environment, throat pain, bouts of choking, diplophonia. Symptom of superior laryngeal nerve damage: swallowing difficulties, chronic coughing, global sensation, hypersensitivity of abnormal sensation, vocal fold spasms, pain or vocal use, loss of voice or high pitch ranges. Causes: congenital or conditions are implicated in vocal fold paralysis include neurological disorders like hydrocephalus and Arnold's Chiari malformation. Dysmorphic neurological disorders such as Moebius syndrome or Golder syndrome, anatomical abnormalities such as tracheoesophageal fistula, vascular anomalies affecting the vocal mechanism, symptoms affecting brainstem function or atrophic disease such as Charcot-Marie tooth. In absence of imaging, either invasive or non-invasive, congenital vocal fold paralysis can be detected in infants through the presence of stridor, a high-pitched wheezing resulting from a blockage of the larynx or trachea, difficulty in feeding, and abnormal sounding cry, excessive hoarseness. Recovering from congenital vocal fold paralysis varies from the reliant of severity of the condition. Some cases of the vocal fold paralysis recover spontaneously, often within the first year. If the paralysis is persistent, surgical conditions such as vocal fold injection or tracheotomy can be taken into consideration. Infection: many viral infections have been reported as a cause of vocal fold paralysis, including herpes simplex virus, Epstein-Barr virus, Bacillus zoster, HIV, West Nile virus, upper respiratory infection, bacterial infection also have reported to vocal fold paralysis. Tumors: when abnormal cells group together in the body, they stay said to form a tumor. Tumors can be either malignant or benign. The paralysis vocal fold and the effect of the laryngeal nerve either directly or indirectly. RNL paralysis can be caused by tumors of the thyroid, lung, esophagus, and mediastinum. Trauma. Vocal fold paralysis can result from the trauma one or more laryngeal nerves during intubation, surgery, infection, botulinum neurotoxin, penetrating neck trauma. Diagnosis. There are a variety of ways to diagnose vocal fold paralysis. Important indication of possible causes can be related in the patient's medial history, which may inform diagnostic approaches taken. Voice diagnostics are used to assess voice quality and voice performance. Vocal assessment is necessary to plan or estimate the success of possible speech therapy. Diagnosis based on auditory perceptual evaluation. Auditory perceptual conducted by speech language pathologist and allows changes in the vocal quality to be monitored over time. There are two scales which can be used to subjectively measure voice quality is Gravas and KV. The Gravas is used to rate patient's voice quality on 5 dimensions: grade, overall severity, roughness, breathiness, asthenia, and strain. Each dimension will receive a severity rating from 0 to 3. This allows SLP to make a judgment about overall severity. An ENT endoscopy with additional imaging techniques, computed tomography of chest, particularly in case of left-sided paralysis, and magnetic resonance imaging of the neck, including the base of the skull of the brain, ultrasound examination of the neck, are performed to exclude tumors along the laryngeal nerves. When tumor formation is suspected, parts of hypopharynx and the upper esophagus and passive mobility, adenoid cartilage, and the esophageal examined under anesthesia. Classification: the unilateral paralysis, bilateral paralysis. Treatment: the treatment of the vocal cord paralysis varies depending on its cause and main symptoms. For example, if laryngeal nerve paralysis caused by a tumor, suitable therapy should be initiated. In the absence of any additional pathology, the first step of clinical management should be observation to determine whether spontaneous nerve recovery will occur. Voice therapy with a speech language pathologist is suitable at this to help manage compensatory vocal behavior which may manifest in response to the paralysis. Voice therapy: the overall goal of the voice therapy is to narrow the glottis without causing hyperfunction of the surrounding muscles. In the past, forced adduction exercises were used to push the vocal folds together but often resulted in the additional stress of the vocal folds. Current methods focus more generally on improving the abdominal support, muscle strength, and agility. Hard glottal attacks. Hard glottal attacks involve building up subglottal pressure, air pressure below the vocal folds before letting out a vowel sound. Often this method is beneficial for the clients who compensate by use of falsetto register. Abdominal breathing training: a breath support essential for those clients who identify as professional voice user. Shifting the awareness of the beneath breathe to the belly aids in efficient vocal function, reducing the risk of hyperfunction and muscular tension. Thank you. Hope you like the video. Please like and subscribe and share with your friends.